Good afternoon. Welcome everybody to Pulmonary Grand Rounds. I'm Luke Davis, and it's my pleasure today to introduce today's speaker, Dr. Kevin Schwartzman, who's a friend and colleague. Kevin is an internationally recognized expert in tuberculosis, and he is currently professor with tenure and associate director of research in the Department of Medicine at the McGill University School of Medicine. He's also a attending physician and immediate past director of the respiratory division at the McGill University Health Center. Kevin is also a principal investigator based in McGill's Respiratory Epidemiology and Clinical Research Unit and in the McGill International Tuberculosis Center. In addition, Kevin also serves, and I kind of enjoyed reading of this, as a standing member of the Commission de la Santé de la Sécurité au Travail, which is the Montreal Workmen's Compensation Board for lung disease. And if you speak French, you can speak with Kevin afterwards. Kevin obtained his bachelor's degree in history and science from Harvard College and did his medical degree, internal medicine residency, and respiratory medicine fellowship at McGill. After returning briefly to Harvard for an MPH, where I think he worked with our own David Pelletier, he assumed a faculty position at McGill, and since he's been there for a number of years, has received numerous awards for his teaching, research, and leadership, and he's a fellow of the Canadian Academy of Health Sciences. He's also associate editor of several leading journals in tuberculosis and global health, and of the Canadian Journal of Respiratory Critical Care and Sleep Medicine. Kevin's research focuses on using mathematical modeling to evaluate the impact of novel strategies for tuberculosis. And this very generalizable method has been very helpful and allowed Kevin to explore many of the new strategies, tools, and technologies that have been developed in recent years to try to understand how we might better eliminate tuberculosis as a public health threat in low-burden countries and in high-burden countries. And this is just a few examples of this as the use of whole genome sequencing for understanding TB transmission, the use of digital adherence technologies to improve outcomes of tuberculosis treatment, and the use of novel short-course TB preventive therapy regimens to decrease progression from latent to active TB. He also has a long-standing interest in partnership with Inuit communities in Canada to try to understand the high burden of tuberculosis in these settings, which I think we'll talk a little bit about in his talk today and tomorrow. So I just want you to join me in giving a warm welcome to Dr. Kevin Schwartzman here at Yale.
Thank you, Luke, for that actually rather humbling and too kind introduction. I'm really privileged to be here today, and I want to thank Luke and Debbie and Richard and Naftali and everybody else for helping to make this a possibility. It was kind of a random thing. I met Luke at one of the TB conferences. I mentioned my son is actually doing his PhD here at Yale. I said, oh, we should invite you. I mean, we'll say those things all the time, but Luke, to his credit, actually followed through. So thank you so much, and it's really a treat to be with you today. And I've loved meeting the people I've met with so far today. Incredible group of people. You guys are incredibly blessed, and I feel blessed to have been able to come. So my talk is on challenges in TB prevention and care in Canada, and tomorrow there'll be a kind of more research and modeling focused talk. So today I'm going to be focusing more on sort of history, public health, that sort of thing. This is the required CME disclosure. So I'm on a DSMB for a clinical trial of a completely unrelated agent, nothing to do with TB. That's the only sort of, I guess, pertinent financial relationship that Yale expects me to share. From my own point of view, my research is funded by the Canadian Institutes of Health Research and the Gates Foundation. I've mentioned the DSMB. Also, in terms of important disclosures, I'm a recovering division director. And in an earlier life, I was the residency program director for respiratory medicine at McGill. So you would call it the fellowship program director. So I'm hoping that through this presentation, we're going to touch briefly on key elements of TB elimination in the global context. I'm going to go rather quickly through that just in the interest of time, but I will talk more about recent trends, similarities, and differences in Canadian versus US TB epidemiology, try and place such differences and similarities in the context of differing histories and health systems. And I think hopefully during the Q&A we'll have a bit more time to talk about that. And then finally to touch on some potential advantages and limitations of approaches to TB elimination in the two countries, both low-burden countries, of course, as Luke has mentioned. So I think just on a personal level, I've met some of you, but many not. I think it's useful always to take a step back and think about where you've come from. So my own undergraduate degree was in history and science, as Luke has mentioned. And of course, Sir William Osler, who was Canadian, famously said that TB is a social disease with a medical aspect. And so with that said, TB was kind of a natural draw or interest as an internal medicine resident. And I also liked clinical epi, but on the other hand, research was not at all part of our culture as internal medicine residents in the early part of the 1990s. As you would, those of you who were there will know, and others will imagine, there was a lot of HIV. There was a lot of other stuff going on. And frankly, the residency system in those days was such that we're primarily concerned actually with survival and surviving, 30-hour shifts, every few nights, that kind of thing. Anyway, that being said, I was fortunate to benefit from a really quite different culture when I joined pulmonary medicine, first as a fellow, and even more serendipitously, I got great advice from my near peers who connected me with somebody who was just kind of emerging as a talent, which is Dick Menzies, whom Luke knows, but was really like a junior faculty then, not particularly well known by anybody and kind of doing his own thing. TB was not a big hit, let's say, at McGill in those days. People did asthma, they did COPD, they did a lot of physiology. But I connected with Dick and ultimately published my first research project in the Blue Journal about a year later, focusing on TB infection among healthcare workers, and kind of took off from there, shall we say. I was lucky enough to join, on the other hand, an outstanding pulmonary division, which was based in several main hospitals at the time before a series of mergers. But at the Royal Vic, which was one of our key training hospitals, on the left part of this photo, which I love and is in my office, that's Peter Macklem, who was a leading pulmonary physiologist and founded the Meekins Christie Labs. And that's Peter Paré. I don't know if any of you have used the Fraser and Paré textbook or you've heard of it. It was our Bible. It really focuses on the approach to differential diagnosis in pulmonary medicine, focused according to imaging patterns. And he literally wrote that book. And a fun fact is that his granddaughter was a star of Mad Men. I can tell you more about that later. She played Don Draper's kind of mistress or whatever, not his wife, but the woman he gets involved with later, Jessica Parry. And then I'm going to speak more about Dr. Becklake on the extreme left of this in just a second. But just to say that this was a very strong division, both clinically and research-wise. Again, with research primarily in respiratory physiology. But Dr. Becklake, one of the few people that I always called Dr. Whatever, no matter how long I was on faculty, was an amazing person and mentor. I never did research with her, but she was a formidable role model. And I want to say a bit about that before getting into the meat of this talk. So she came from South Africa, as did her husband. Her husband still is alive. He's about 100. He's a cardiologist. And he became the chair of medicine and the dean of medicine at McGill. She literally established respiratory epidemiology. She led pioneering work in occupational lung disease and asthma epidemiology, multiple honors. But importantly, I think from today's perspective, she, despite having a husband, again, who was also an academic star in medicine, she raised a family in the 1950s and 1960s, and very importantly, was a lifelong social justice advocate. And this quote from her obituary in the Toronto Globe and Mail, which is kind of Canada's New York Times, kind of crystallizes that. So she would go with her husband to the townships in Joburg to drive Black residents to the city because they had so far to travel. And she knew that it was the right thing to do, despite the fact that she might be arrested at any time for doing this. And so, in fact, in her memory, shortly after she died, we set up a fellowship specifically to fund young graduate students and clinical folks training and research to come to McGill from either low and middle income countries or indigenous communities to be trained in respiratory research and to bring that back to their own settings and communities, really in her honor. So I wanted to pay credit to her because she was such an important influence on me, even though I never did any research in asthma or occupational lung disease. The Royal Edward Institute, which is the forerunner of the Montreal Chest Institute, where I still work, was originally founded in 1909 as a TB dispensary. Like many pulmonary organizations and facilities, our roots are in TB. And what was interesting was that it was open. Remember, Canada was semi-independent at that time. It was kind of had autonomy over its internal affairs, but for international stuff, was still the King of England was the head of state, and we fought in wars that England said we had to fight in, kind of thing. And King Edward presided over the opening from England, and he sent a telegraph signal, which basically opened the doors of the new facility, and the flag went up the flagpole based on this telegraph signal. And we actually still have part of that in the wall outside our door in this megalopolis hospital that I'm going to show you in a minute. These are just photographs of the same. This facility moved in the 1930s to this building, which part of which was a hospital and part of which was a school for children of people with TB. And then in the 1950s, the part on the left was built really to accommodate what was thought to be the growing need for TB-related thoracic surgery. And of course, that was then precisely the time that the anti-TB antibiotics came into play. And so the surgery for TB kind of fell by the wayside. People no longer needed to be hospitalized to be treated for TB. And so this facility really moved its focus to other respiratory diseases, as was the case, fairly universally in the pulmonary disease world. And then finally in 2015, and part of the reason I have so much gray hair, because I was a division director at the time, is that we moved to this brand new facility located actually a couple of miles from downtown Montreal. And we have kind of a clinic right around here and a day hospital and one floor or 2/3 of a floor in a hospital and kind of up here. So we went from this little hospital that the physicians and nurses and RTs basically ran to this huge place where we're just a kind of small cog, but we try and keep our identity. I can tell you more about that after. So I'm going to, as with all good pulmonary presentations, I'm going to start with a couple of x-rays and then we'll get into the meat of it. So this first one is a patient of mine. She's a 43-year-old woman who's been in Canada from the Congo for a long time, no past medical history, HIV seronegative, but who had repeatedly gone back to the Congo, most recently in the spring of last year. And she was seen last August with the usual persistent cough, not better with antibiotics, and this x-ray. Her sputum was smear negative, she's PCR culture positive, uneventful treatment completion with radiographic improvement, and 2 or 3 kids who I think at least some of whom were born in Canada were also tuberculosis skin test positive. And this is just kind of emblematic. The patients we see who are foreign born, who go back to their home countries for visits. We don't know if they had TB infection with them when they first arrived or they caught it on subsequent visits home. But again, in our healthcare system, TB is not particularly frequent. So the classic story is exactly this. Somebody gets antibiotics, they continue to have the same symptoms, they get a second round of antibiotics, it goes on, and finally kind of the light bulb goes on and they get tested for TB. This other case is a bit more dramatic and it deals with the other sort of main track that I'll talk about today. So this is a 19-year-old man born in Canada, again, no relevant past history, tobacco and marijuana use, no alcohol, who was actually brought to his local hospital, and we'll say more about that in a second, after 3 tonic-clonic seizures kind of out of the blue. So we started on Keppra, given IV antibiotics for possible meningitis, but then transferred to us. While at his local hospital, actually confessed that he'd been coughing for several days. So an x-ray was done, which showed obvious left hilar enlargement and probably something up here with an unremarkable physical exam. So in fact, his induced sputum was NAT positive for MTB without rifampin resistance. Again, the sputum specimens were smear negative but culture positive. You can see on the scan adenopathy here and here. You can see this sort of cavitary area near the left apex. He provided no known history of TB exposure, but it turned out that both his parents were being treated for latent TB infection. He himself was HIV negative. He also had this in his cerebellum and another frontal lesion, which you don't see here. But the key point here is that this 19-year-old came from a village in Nunavik, which is the Inuit territory of northern Quebec. It consists of 14 villages. The total population there is about 13,000. And this, not of the village, but of the entire region. The villages typically have between 500 and 1,000 people living there. And this particular village was known to have experienced recent TB outbreaks. And we're going to come back to that point later on. So he was started again on standard first-line treatment plus prednisone. Keppra was continued. And ultimately, he was discharged home back to the north after spending 4 weeks with us in Montreal. And to me, I mean, again, as somebody who's interested in history and interested in kind of social aspects of medicine, I think it's worth asking ourselves, why is this happening? Why does a 19-year-old born in Canada come in with both pulmonary, undiagnosed pulmonary and CNS TB? And we'll talk about this more a bit later. So just to put things in context, many of you may know this, pre-elimination is defined as annual incidence of less than 1 per 100,000, elimination less than 1 per million. We're talking about cases of active TB disease per year, compared with the estimated annual global TB incidence by the WHO, about 130 per 100,000. So clearly, we're way, way, way off that. In Canada, our annual incidence has tanked at about 5 per 100,000 for the last 20 years. It hasn't budged. In the United States, last year it was 2.9, which was a 15% increase from 2022. And we'll look at the curves a bit later. But the key point here is that in Canada, our rate is roughly twice that of the US. And we'll get into some of the possible reasons for that a little later on. Some of you will be familiar with the WHO NTB strategy, first adopted in 2015, with further guidance in 2022. And again, this is where I'm going to go a little fast, but basically it's promotes or promulgates a holistic approach to ending TB, focused not only on sort of medical technical interventions, but also the health systems in which TB is cared for or not, and the social determinants or background where TB flourishes. And again, so there's emphasis both on medical and technical interventions, but also healthcare access, social determinants, and research as the way forward. And again, you can see that in the schematic here. I think the slides will be shared, so I'm not going to read these in detail, but again, focus on patient-centered care and prevention. Important shout out to health policy and supportive systems, and again, research and innovation. And again, I'm not going to read each of these in detail, but just to say that I think when one gives a TB talk, I feel that it's important to provide some global context and not just focus on the sort of immediate issues at home. One of the things about the global TB strategy, and it's something that kind of as a pulmonologist, I have to reset kind of my thinking, is that in public health, it's really important to have milestones, targets, and then strategies to get there, and sort of KPIs, if you will, key indicators that you can measure performance against. And so we see that pretty clearly now in the TB world with fairly well articulated milestones and targets from 2020 forward at the global level. Major targeted increase in TB deaths, TB incidents, and avoidance of catastrophic costs, here defined as more than 20% of annual household income. These are obviously very ambitious targets, and the sad fact is that it's pretty clear that at least for the 2025 ones, we're far off. So you can see here, for example, it was targeted that we should reduce case rates by half from 2015 to 2025, and as of 2022, case rates have been reduced by less than 9%, and so on. The one area where we have, I won't say we've made progress, where it's not quite as bad, is not 100% of people face catastrophic costs, but clearly we're way off the mark as far as meeting targets to date. Again, you can see with TB treatment, a ways to go, particularly in children and with drug-resistant TB disease. So again, even before, before the pandemic, it was becoming clear that we probably weren't going to meet these targets, and of course, the pandemic just made things that much worse, right? So you can see the global curves over a dozen years roughly, before and then through much of the COVID pandemic. And we saw actually a decrease in case notifications related to basically more limited access to diagnosis and care during the pandemic, during the worst of the pandemic in particular, and then a rebound, part of which is just catch up, but part of which is probably more transmission during the period that we were diagnosing TB less well and starting fewer people on treatment. The total here is what the WHO estimates to have been the total number of people who developed TB disease, as opposed to those who were reported. We do see a reduction in people living with HIV, largely related to the rollout of ART. So this is, again, millions. This is case rates. The message is the same from both halves of the screen. What about in Canada? So as I've said, in Canada, really our case rates haven't changed for, it's really 20 years. If we went back another 10 years, it would be the same. Really hovering around 5 cases per 100,000. In 2022, the most recent year for which we have data, 5.1 per 100,000. So we hover a little under 2,000 cases a year in total, sort of 1,800-ish plus or minus. Whereas in the United States, the curve is quite different. Obviously, there were very bad days for TB in the early 1990s. Again, some here will remember those well, others will have heard about them. Resurgence fueled by HIV, by epidemics of multi-drug resistant TB disease in healthcare facilities, particularly in large cities, and essentially by neglect of the public health system, I think it's fair to say. And certainly if you read similar seminal papers like the one from New York City in 1995, it's very clear that what made the difference was reinvesting in public health, TB care and prevention. It wasn't new treatments for MDR-TB, which didn't exist at the time. It was basically treating people properly, making sure they stayed on treatment, finding their contacts, sort of public health 101 when it comes to TB. Be that as it may, there was a marked drop in both incidence, in case rates and numbers over the next few decades, to the point where, as I've said, the incidence in the US has been about half of that in Canada in the most recent years, with some rebound post-COVID. In Canada, as in the United States, foreign-born people account for the preponderance, of those with TB disease, over 3/4. What's different in Canada is that a sixth relate to Indigenous peoples, okay? Just way higher share than in the United States. And we see actually a tiny number of people who are Canadian-born but non-Indigenous. So they account for less than 4% and just about 50 in absolute numbers. So all this to say that TB you'll see the incidence rates in a moment, TB in Canadian-born people who are not Indigenous, we're beyond pre-elimination actually, but we're clearly not doing well with the other groups. And this is just showing the same thing or similar points graphically. And what I've circled here is Inuit. So as I said, global overall case rate 130 per 100,000, Inuit 135. It varies a lot from year to year because it's a small group in absolute numbers. It's about 60,000 Inuit people living in Canada. So obviously, one big outbreak can make a huge difference with a population that size. But there have certainly been plenty of years where it was 200 per 100,000 or more. So that's on par really with much of sub-Saharan Africa. And I think, when confronted with this publicly, yes, the Canadian government will admit that this is an embarrassment, and it's become quite politicized. But it's really a black mark, I think, on Canada that this continues to go on. And we'll talk about some of the reasons for it in a few minutes. If we go down from there, again, First Nations, which would correspond to Native Americans in the United States, about 16 per 100,000 in 2021, where we have data. And this is just the same thing, but with the axes change so that the Inuit no longer appear, and so you can kind of see where everybody else is. And so again, you can see that in non-Indigenous Canadian-born people, we're actually almost at elimination. We're well below pre-elimination, we're almost at elimination. The details of the slide are not at all important, but it's just to say that MDR, we can't blame MDR. MDR and XDR account for about 1% of TB annually in Canada, so that is not the issue. Likewise, HIV, not a major player in TB epidemiology in Canada, and specifically not in Indigenous peoples. So it's really, we can't sort of put it on that or say, if we did a better job with ART, we'd have less TB. That is not what's going on here. And lastly, in terms of case fatality, also not great. About 5% of people who develop TB disease in a given year will die from or related to it. So this excludes people who have TB and got hit by a truck or whatever. This is people who death is thought to be attributable largely or at least in part to TB, and it's about 5% higher in some years, which again is really not fantastic. So key gaps, just to summarize. As I've said, incidence largely unchanged for the last 20 years, concentrated in foreign-born and Indigenous. One, again, kind of if you work in TB in Canada, we feel this is glaring, is that our surveillance data have been very poorly done. There were major delays in sharing data. In other words, making what is like standard public health data, making it publicly available, or available even to like people who work in TB. Whereas in the United States, this is done religiously. And this is something we have not been doing well. The case report forms that are submitted by provincial public health authorities to the feds are outdated. A lot of fields just don't even get filled in. They haven't been updated in at least 10 years, if not more. As I said, limited data is provided not just to the feds, but by the feds. It's very cursory what gets shared. And really what this means is that we can't, as people working to hopefully eliminate TB one day, we don't have the data we need even to make proper decisions. There's been a lot of political sort of advocacy around this point, and I'm happy to say things may be starting to change, but it's really been difficult. And again, to my mind, actually quite a glaring gap is that our reported treatment success rates are only 75 to 80%, and this is partly because anywhere from 5 to 10% are reported as not evaluated for final outcome in any given year, which again, to me, that's in Canada, that shouldn't be acceptable. I mean, we have a publicly funded healthcare system. People don't have to pay to see a doctor. Obviously, TB is also, TB, not direct care, but management reporting stuff is supported by public health authorities. This shouldn't be happening, but it does. I would say it starts at the top, as with many things. And again, I'm not afraid to say in this context that there's been really a lack of clear leadership and coordination at the national level that goes well before the COVID pandemic. COVID made it worse, but it wasn't because of COVID. So for example, when I was a younger faculty member, we had what was called the Canadian Tuberculosis Committee, which brought together the feds, especially those from the key agencies that deal with TB, each of the provinces, their public health lead for TB, academics, probably should have had more community representation, which we didn't at the time, but this was a long time ago, and that was disbanded. And in fact, they had one sort of subcommittee that dealt exclusively with immigration and foreign-born TB issues, another subcommittee that dealt with Indigenous health issues. And again, all of this was disbanded, basically because it was a more right-wing government at the time. They felt that the government should disengage from sort of being involved in health policy. They wanted to save money. There's also major jurisdictional fights essentially over healthcare in Canada. As per our constitution, healthcare and education are primarily provincial responsibilities. So, and the provinces, like for example, my own province, we can talk about it later, but there's a lot of issues between the Quebec provincial government and the federal government. And anytime the federal government makes even the inkling of a suggestion about what they might do in health, there is like a huge backlash. It's in all the newspapers. There's threats of separation, all that kind of stuff. So it's a very politically charged thing. And then again, there's multiple federal agencies with their fingers in the pot. Public Health Agency of Canada, which would be theory the equivalent to CDC, but doesn't perform in any way at the same level. IRCC, which deals with all the immigration issues, and Indigenous Services Canada, which deals with healthcare provision to some Indigenous communities. Actually, largely not the Inuit communities, but some of the others. Again, and we have no clear national plan to eliminate TB, although again, finally, I just learned that may be changing, frankly, because academics and others have been pushing hard, and because the public health authorities can now finally turn their attention to other things post-COVID. And again, I'm not going to read through this at all, but just this is on the US CDC website. Anybody can see this. Again, in the US, they have a division of TB elimination. That vocabulary doesn't exist in any Canadian agency. And there's a pretty well articulated strategic plan, which again, I'm not going to read, but you can go see it. And there's, I think there's sub-pages on a number of these things, but it's like articulated. You might not agree with it, but at least it's out there. We don't have any such thing that's been articulated and visible to people. And this is, I love this. This is my colleague, Jonathan Campbell. Some of you may know, he was a postdoc with Dick Menzies and with me, and then is now a junior faculty colleague. And this is kind of an opinion piece he published with colleagues in the Canadian Journal of Public Health. But this graph is simply showing in the United States, you know, there's a TB surveillance report that comes out every year. I think it comes out in March, if I'm not mistaken. You guys would know. But year after year, it comes out, a predictable time, short time after the end of the year in question. In Canada, these are the lags that we have in months. So we've had years where the TB surveillance data for that year only came out 4 years later. So how is that actionable from a public health point of view? I don't know. I certainly couldn't tell you, but this I think is pretty flagrant. And these data are all, by the way, you can't ask to have them sent to you. These data are kind of only made available, they're posted, and that's when you can see them. So just as kind of a report card, I'm not going to go through line by line, but this is by one of the advocacy groups, Stop TB Canada, and you can see most is in red, like in other words, not good. And this is 2024. So there is one group in Canada that has articulated a very explicit TB elimination plan, and that is actually Inuit Tapir Kanatami, which is the National Inuit Organization of Canada. And in 2018, they published a framework for TB elimination. You can see that it's kind of a cool symbol. The white maple leaf is kind of embedded in the design. And just to kind of orient or situate you, as I mentioned, there's about 60,000 Inuit people living in Canada, so it's a small population. They're very dispersed geographically. Inuit Nunangat, which is the Inuktitut term for the Inuit homelands, consists of 4 regions. One, the kind of very northern edge of what is called the Northwest Territories. This actually has very low TB incidence. Nunavut, which is a new territory, I think that was carved out in 1997 from the former Northwest Territories, that is considered kind of the primary Inuit homeland, and it's actually Inuit governed, unlike the others. Its largest town and capital is Iqaluit on Baffin Island, shown here. I think it's the population of that community is about 8,000, if I'm not mistaken. We have Nunavik, which is the northern sort of half or so of Quebec, the Quebec landmass where I live. And finally, a sliver of Labrador here, Nunatsiavut. Nunavik, which I'm going to talk about a bit more, where that gentleman came from in the case presentation, I'll talk about a bit more, I think, later today and also tomorrow, has 14 villages. You can see they're all spread along the coast, either of Hudson Bay here or Ungava Bay here. What's important about these communities, as with most of the communities in Nunavut, is that there's no road access. So they're not connected to each other by road. They're not connected to anywhere else by road. They're mostly fly in, fly out. In the warm months, in the summer, it's possible to get to them by boat. Same with some of the Nunavut communities. I don't think the ones in the furthest north, but certainly Iqaluit you can get to by boat, which means that, so that has huge implications, for example, for construction. So overcrowding is a big issue in terms of TB, and to build new housing is incredibly expensive, right? Because nothing can be brought in by truck. It's all by boat or by air. And likewise for healthcare. So these villages, most of them just have a nursing station with docs that come in from time to time. There's 2 communities that have hospitals. Those hospitals have limited capacity, both in terms of bed numbers, but also technical capacity. So for example, that they don't have CT scans. They don't have most medical specialties. So it's actually like family physicians do a lot of all kinds of stuff. They do trauma, they do this, they do that. TB obviously is just one of many things they have to deal with. And so as I mentioned, for advanced care, certainly for tertiary care, it's actually our hospital that has the primary responsibility for all these communities. So if there's a TB issue that can't be dealt with in the north, they come to us. For Nunavut, it's a bit different. I think for some of Nunavut, Ottawa is their referral center. For other parts, it may be, I think it's Alberta and to some extent Winnipeg. So just to come back to the ITK TB elimination plan, again, I'm not going to read the details, but they say their goal is to reduce the rate of active TB disease by at least 50%. So using 2016 data from about 180 per 100,000 to about 90 per 100,000, which is still very high, but half what it was. And again, there's all the right things about continued reporting, making changes according to progress, and so on. And again, their plan is elimination by 2030. Again, I'm not going to read these line by line, but I think it's important to highlight front and center the meaningful involvement of Inuit people and communities, respect for values, language, knowledge, culture, and the historical context, which I will come back to, which is super important. And then other points, health equity, youth, etc. Okay. And then in terms of the actual steps to be taken, so obviously the medical and nursing aspects of TB care and prevention, but also poverty, social determinants, community mobilization, capacity building, again, the importance of Inuit specificity and accountability, which has been, I think, hopefully you'll see or agree, in many spheres has been lacking. This is where it becomes super important to take a step back and look at history. And this is a history that I wasn't taught growing up. So I think a number of you will have heard about the residential schools. They exist in the US as well as in Canada. So these are schools where Indigenous people basically were forced to go. Police would actually come and take them from their families if they didn't want to go, and they were shipped often very far away. These are residential schools, so they couldn't go back home. Those who tried to escape were basically captured and brought back or died in the cold in some cases. TB was rampant in these schools. Many children died of TB, and sort of coupled, and this has obviously been a huge source of trauma and ongoing sort of controversy, compensation, et cetera, in Canada. Again, it's something that I never learned about growing up. It's something that really has become part of the public discourse more recently. But kind of twin to that is TB and how the degree to which it was enmeshed in our colonial history. So again, similar to the US, this part is similar. Inuit had incredible TB rates and death rates for much of the 20th century, kind of until, frankly, some of the pivotal work that was done in preventive therapy in Alaska by Comstock, and so like that's when kind of things started to improve, right? But what's noteworthy in Canada was that in some communities in the Inuit, up to 25% of people were sent south, meaning they went to sanatoria and hospitals in southern Canada. They were brought by boat, again, during the summer months, and then train or whatever it was. And many of them never returned home. They died in those places, and their families got zero information about why they were taken away, what happened to them, where they're buried, like nothing. And that is obviously, we consider that completely unacceptable today, but this was like, that's the way things were. And so what I'm showing in this photograph is the CD Howe, which is a ship that belonged to the Canadian government, and it would go from village to village along those coasts. They had an X-ray machine on board. It would basically herd everyone into the boat, and those who had something bad, whatever, quote unquote, on their X-ray, you stay on the boat, your X-ray is okay, you can get off the boat. And then the boat just left and went on to the next place, and the next place, and then went south and brought people to the sands or to the hospitals. And again, many were never heard from again. And of course, there was no real notion of explaining to people in their own language what was happening, why, what to expect, none of that, right? And so this is really why TB has a very loaded subject when we talk about TB, or when we try and engage with Indigenous communities around TB. It is extremely loaded. It's a traumatic subject. There's a lot of stigma, a lot of fear, and obviously well-founded mistrust of the medical system when it comes to TB. And so that's why I highlighted the fact that, you know, the well-meaning person who comes from Southern Canada saying, I'm going to solve your TB problem, that doesn't work at all. It just is bound to fail and just creates resentment appropriately and mistrust. So again, important that any interventions that we think about, whatever they might be, have to be done by and with, not for, the communities in question. And what I've shown here on the right, this is a very sobering read. It's actually by a pediatrician at McGill. It's called Fighting for a Hand to Hold. And what he starts with, the sort of his starting point, he's an emergency physician in peds, was the fact that until literally a year or two ago, when there were medevacs from northern Quebec for kids, their parents were not allowed on board. The kids were sent down alone. whether it's from Inuit or Cree communities. The kids were sent alone, might not speak English or French, didn't matter. There was no provision for their parents to accompany them. This was, of course, there were all kinds of challenges to the Quebec government, which refused to back down until finally there was this guy actually lit a public furor, and then finally, after a lot of back and forth, the Quebec government relented. And then this led to a book that, again, painfully accounts a number of instances of frankly shameful treatment of Indigenous people by the healthcare system and let's say their enablers. This is one of my favorite movies. It's a Quebec movie, actually. It's Ce qu'il faut pour vivre, or the English title is The Necessities of Life. And it's actually about an Inuit guy called Tivi, who is, that boat comes to his village. He gets scooped up, again, with no explanation. He's brought to a sanatorium near Quebec City in the 1950s. This is what we used to have nursing sisters who were associated with the Catholic Church. And she's sort of this well-meaning young nurse who's kind of trying to help him adapt, understand what's going on, and so on. Anyway, it's a great movie if you ever have the chance. And you can find it. I don't know if it's on Netflix or you can just order a copy, but it's well worth watching. So, turning back to the US and the contrast with the US. So again, you can see that the case rates for what would correspond to our Indigenous peoples are much lower in the US. So they have around 5 per 100,000, as I said. Ours are more than 3 times that. Whereas in the Caucasian US born rates are very low and actually relatively similar to our non-Indigenous rate in Canada. Our rates in the foreign born are probably quite similar. But what you see here, so this is actually by Dick Menzies and colleagues, and they actually tried to sort of disarticulate this a little bit or see what was going on here. And you can see that, again, as mentioned, kind of with the advent of mass BCG vaccination, widespread use of isoniazid preventive therapy, better treatment for TB disease, TB case rates fell across all Indigenous communities. But then in recent years, they picked up again, really in 3 main groups. In Greenland, the Inuit of Nunavut, which as I said is the northernmost territory of Canada, and Nunavik, which is northern Quebec. In the other Indigenous communities, they haven't sort of rekindled in the same manner. They tried to look at some of the reasons for this. The resurgence seemed to be associated with the prevalence of smoking, inversely with essentially better nutrition, which in turn can lead to diabetes and obesity and high school completion. Whereas the increased incidence, as you would expect, associated with improvements in general health, so better healthcare, better social conditions, as captured by life expectancy to infant mortality. And again, there were some medical interventions that also were likely of benefit. All of these were all kind of ecologic studies with the weaknesses those have. Again, we'll talk about a bit more in detail tomorrow for those who come. Approaches to this have to be developed in partnership, but community-wide screening for disease and infection is promising, and that's been done in the highest sort of outbreak communities with some success and buy-in from the community. One of my close colleagues and friends has launched a major program to help with the training of local community health workers to support TB testing and treatments. One of those people who don't come from outside, who are from the local community, who are not formal health professionals, but have the basic training they need to accomplish this. Improve access to diagnostics, and then again, improve the major health human resource challenges we have in terms of recruiting and retaining health professionals to these communities. And again, upstream social and behavioral determinants is super important. As I'll show tomorrow, maybe short-term impact on TB is quite limited, but obviously have many, many other good reasons to engage in. Again, if you look at the foreign-born, this is the last piece of the talk, we see that in the foreign-born in the United States, actually incidence has been going down, although again, it's a bit lower than in Canada. It's about 13 per 100,000. In Canada, it was slightly higher, but quite similar. Interestingly, this was actually higher in the US before, as the curve shows. Part of the reason for that is kind of artificial in the sense that until 2007, to enter the United States as a permanent resident, you just have to have negative smears. So you could actually have prevalent TB disease that was smear negative. and you were then diagnosed in the US and counted in the US case figures. So that was changed in 2007, so that no longer exists as a difference. Whereas in Canada, it's always been the case that you have to have negative cultures on screening abroad. As in the US, people who are newly arrived permanent residents in Canada are required to undergo surveillance after they arrive if they're thought to be at high risk for progression to TB disease in the short term, so usually based on extensive radiographic scarring or a personal history of previous TB disease. But in fact, research by colleagues both further back in time and more recently has shown that this is actually quite a low yield way of detecting and preventing TB. So for example, in Ontario, 2/3 of TB disease that occurred in the first decade of this century involved persons who had, in foreign-born people who recently arrived. Most had not been flagged for surveillance because they had normal X-rays when they arrived. So they were not flagged in any way. The US, as we talked about with a couple of colleagues today, is now intensifying screening instructions for TB infection among new arrivals. So in fact, they will be required to undergo an IGRA, interferon gamma release assay, as well as an X-ray, if they come from a country of incidence 20 per 100,000 or more, which includes Mexico. Testing abroad is conducted at the expense of the applicants. Treatment for TB infection is not required as a condition of entry. So TB disease, yes. TB infection, no. But those with positive IGRA results will be flagged. And the implication, of course, is that somehow local programs and providers will pick up the slack and initiate treatment. And if we come back to the person I mentioned at the beginning, obviously that doesn't touch the people who are born abroad who are already in the United States and Canada, nor does it touch TB infection that's acquired after they arrive through visits home. So just kind of back of the envelope calculations, it's likely that about 20 to 25% of that group overall will test positive, with much higher proportions in older adults from some of the main source countries in India, Philippines, Vietnam, and so on. So this is a major undertaking in terms of logistics and costs, and we'll talk about cost effectiveness tomorrow. Canada has taken a much more limited approach. So far, we've only expanded screening for TB infection among those known to be close contacts, to be living with HIV or on dialysis. But again, this doesn't deal with the reservoir infection among people already in the US and Canada, who at an individual level probably have a low risk of future TB disease. And just a shout out to Marcel Baer, who some of you may know, advocating for the fact that many people may actually self-clear their TB infection over the years. So essentially further arguing that people who've been in our countries for a long time may not benefit from screening and preventive treatment. And of course, this is all compounded by the human resources crisis that we face in both primary care provision and in public health. So this is, I think this is just about it, but just to wrap up, so this is a cartoon done by Jonathan Campbell, who wrote an opinion piece with me and David Dowdy from Hopkins and PLOS Medicine, kind of showing that to actually accomplish TB elimination in Canada, we have to basically prevent it in 49 out of 50 people who now develop it, and most of them have no official indication right now for testing and treatment for TB infection. They don't have a known medical risk factor. They're not close contacts and so on. And so if we want to eliminate TB, we have to deal with this full group, some of whom are over 65. But again, as individuals, they probably get not much benefit and a lot of risk, in some cases, certainly the over 65 group, from preventive treatment, where at a population level, we know this is what it's going to take. So there's this kind of tension between individual limited benefit and the only path forward to elimination in the foreign-born being mass screening and treatment for TB infection. And just on that note, it's important to recognize that in Canada, over 20% of our population is foreign-born, whereas in the United States, that figure is 14%. We now get 500,000 new immigrants a year against a population of 41 million. Again, I'll talk about this in more detail tomorrow, but in fact, again, we estimate that the prevalence of TB infection in foreign-born Canadians is about 22%. Same thing among recent arrivals, although as you'll see tomorrow, we estimate that the risk of recent infection, in other words, among those, how many were infected in the last couple of years before they arrived, probably very low. And then there's some ongoing modeling work to actually address TB infection screening in the foreign-born, which I'll talk about tomorrow. This is work done 2 decades ago, looking at the benefit of investing in TB care abroad and how it might positively impact TB epidemiology in the United States and Canada. And this is very recent work, actually preprint from medRxiv from Nick Menzies, not Dick, but Nick Menzies' group at Harvard, again, highlighting the potential benefits of TB prevention and care abroad. And again, you can see the details online if interested. So just to summarize and wrap up, again, we talked about roadmaps for global TB elimination, clearly very far from the milestones we'd like to reach. In Canada, as in the US, there's a very large foreign-born component to TB, but we have the added layer of a frankly disastrous situation in some of our Indigenous communities. And for that reason, our incidence is nearly twice that in the US. We do also have some, again, we have more foreign-born people as a proportion of our population in Canada. That would be a small part of it. So even though the incidence per person is similar, we have proportionally more foreign-born people living in Canada as a whole, more new immigrants. But again, a major issue is the health disparities among the Indigenous. We don't have a clear elimination plan, and that relates to leadership, coordination, and reporting. And again, we need to do a better job with Indigenous communities at risk, as well as foreign-born Canadians. Again, it's important to highlight in the case of the Indigenous, it's not homogeneous. We have Indigenous communities with extremely low TB rates. Even some Inuit villages have very low TB rates, haven't had a TB case in years, so this is not universal, but we have some situations where it's really dramatic and not acceptable. So again, final thoughts. I think continued progress will require interventions developed by and with Indigenous communities in true partnership. We need better tools that will allow us to better focus screening and treatment in the foreign-born. So it allows, for example, to pinpoint and treat the group that don't have obvious medical risks, but will down the road develop TB disease. We don't have a good marker for that now. Again, the current tests have actually very poor predictive value for TB disease. And of course, if we had a one-off pill that had no side effects, we'd give it to everybody. But we're so far from that in terms of treating TB infection. So we have a lot of work to do there. And then again, the last piece is, of course, better prevention and care abroad. And I would leave you with perhaps the sort of rhetorical question or reflection point. Is it appropriate to discuss or label TB elimination in North America when we're living in a world where the incidence is 25 or 40 times what we see? And I would just say perhaps it's an important aspirational goal, but it really has to be taken in the global context. So with that, I thank you so much for the kind invitation, and I'll take questions. These are some partners in crime. Dick Menzies, my mentor, Jonathan, who's a brilliant colleague now, Olivia Ari was an MSc student, and then pulmonary colleagues at McGill, Ottawa, and BC, with whom I've had the privilege to work again. Faz and Gonzalo really on a lot of the Inuit stuff. They really kind of changed my thinking, because these are people who work closely with the communities. Faz actually lives half a year in Nunavut, you know, and really have helped evolve my own thinking.
Thank you, Kevin. Great talk. And, you know, I think we've all been thinking a lot with pulmonary disease and TB TB specifically, and pulmonary disease in general, about the role of structural factors in sort of driving the disease. And it's great that you started out with that quote from Osler. And I think your whole talk was a great example. But of course, we know there's a lot of examples in North America, south of the border as well. So thanks for sharing the experience in Canada. My question is kind of a big and broad one. I mean, there's those of us, probably a minority in the TB community, who are interested in implementation. How do we prove the delivery of what we already know? And I think it's kind of a minority. But there's also
it's so important, Luke. It's actually key.
Well, yeah, I mean, I know we believe it is, but if you look at what's happened over the last 15, 20 years, we have so many new tools and technologies. That's where most of the investment has kind of gone. But I think you're painting a bit of a pessimistic picture for the ability for us to control TB with the tools that we have. And so I'm just curious how you think about that. I mean, how do we find these, you know, folks in yellow there that don't have any symptoms, that don't have any indications? Do we really need to be focusing more on kind of new tools to help us identify it, or can we make gains in Canada or in the US or in other places just simply by improving what we already know how to do?
Yeah, thank you. Obviously, an excellent and very important question. So I think there's maybe two parts to that. So the first is, I agree with you like 500% that for the communities most affected by TB, I think we can do a much better job with the tools that we have, in terms of, for example, like again, more culturally appropriate care, developing, again, in the case of Indigenous communities, developing actually care strategies and French Saint-Revenant, like personnel who to work with in and with those communities, who can basically make better use of the diagnostic tools we have, the preventive treatment tools we have, deal with all the cascade of care issues. So for that part, for sure, we could probably do much better with what we have. I think the other piece, like the kind of people in yellow and red in that cartoon, that's a bit different, because to me, I think that's where we need actually, to me, the crying need is better ways to predict who among that large group of people, that small number, will develop TB disease, because giving all of them rifampin for 4 months or 3 months of isoniazid and rifapentine, that's going to be very problematic, both from just a logistical point of view, but also, frankly, these are people who feel totally well. And if you give them the stats, you're going to say, okay, well, we say lifetime 5 to 10%, but let's say somebody's 50 years old, they've already lived a good chunk of their life, maybe they've been in the US for 30 years, so a lot of that risk is already passed. So, well, to eliminate TB, I need you to take this medication. You're not going to like it. You're going to feel kind of nauseous. You might feel tired. You might not be able to work at your maximum level of function for a few months. But we think, at least for the population, is what's going to help us eliminate TB. I know we don't talk about that, but that's a pretty hard sell. Whereas if I said, okay, well, actually, you're different. You have a much higher risk of developing TB disease in the next while, and I have this treatment that really, you're going to take this like you take an antibiotic for an ear infection. It's going to be a week, has few side effects, not going to notice, right? The whole discussion, the whole calculus will be completely different, right? And so I think that's where, almost paradoxically, I think that's where our existing tools fall short, is like at the margin, right? The people, like the communities that are having TB outbreaks, like we would normally expect to see in high burden, high incidence countries, we know what to deal with, what to do, what we should be doing, what should be done to deal with that. I mean, I know the work you've done, right? You work in Uganda. It's not like you don't know what will help bring down TB rates there. It's a question of implementation. I think it's very similar, actually, frankly, in our high burden communities. But again, at the margin where the calculus is quite different, I think that's where we need much better tools. And it's not just, like, again, even if somebody's like the most motivated person in the world, if they have like a 0.2% risk of TB disease and a 3% risk of side effects that will cause them to stop their treatment, that's a very different discussion from the person who's a close contact in a village with, where 10% of the people have developed TB disease in the last year.
A lot of opportunities. Just looking around and see if there's any questions from the audience.
Sorry, like they can't get your steps in. I was just wondering about what's been done to engage the communities, the Inuit communities, because I assume, there's been a lot of work, and I know Yale has done a lot of work working to find partnerships within the communities to increase engagement. And I know at the global level, that's been done a lot with vaccine distribution. And I assume Inuit communities are probably quite insular since they're so isolated. And so I was not to sound ridiculous, but the white doctors coming from Montreal suddenly are potentially going to have less inroads than someone from their own community.
Exactly. So all those points, of course, are super well taken. So and that's precisely right. So the white doctor coming from Montreal, Toronto, Ottawa, whatever, saying this is what we're going to do to quote unquote solve your problem, that doesn't work at all. So in fact, a couple of things. So first of all, the fact that ITK, so the National Inuit Organization, has articulated its own elimination plan, which brings together both some of the more technical medical components and some of the broader ones, but identified that as a priority and priority actions to accomplish that. And they've actually tasked each of the 4 subregions, if you want to call it that, with developing its own elimination plan that is, again, driven not by the outside public health authorities, but in large part by the communities themselves. I think that's been quite important and powerful. I think also, again, my colleagues, I have 2 that actually, FCAHS and Gonzalo, who are both pulmonologists. FCAHS, as I said, spends half his year in Nunavut, and he actually partners with the local communities to articulate what they feel is what their priorities are, what they think is acceptable or not acceptable in terms of interventions, and actually trying to develop a cadre of local CHWs, based community health workers, who, for example, could help with latent TB testing, help support treatment in a basic way, but are people from the local community, so it's not, again, imposed from outside. Gonzalo actually continues to run a project or endeavor called Time at TB, which is Stop TB in Inuktitut. He does that mainly out of Iqaluit in Nunavut. And what they did, for example, a door-to-door screening campaign. But again, it was really community-led. They had community events where they had feasts and stuff like that. There was discussion with and by community members as well as the outsiders, quote unquote, about TB, what it is, why it could be important to do certain things. And actually was able to show pretty significant engagement and also uptake of TB preventive therapy in a number of instances. So I think it's these kinds of initiatives that are most likely to work. And the other thing, two other points. So again, even though yes, geographically the Inuit are quite isolated, they do have a relatively strong national organization. Natan Obed, who's their the president or whatever of ITK, he's actually, I think he may have even done his undergraduate degree at Columbia. He's very articulate. He's very politically connected. He's good friends with Justin. And we could talk about Justin separately. Justin has a lot of issues, but he is politically connected. This is part of the reason actually that TB has been on the agenda and has been on the federal agenda, partly also it's such a black mark, but also because of this kind of visibility. And then likewise, the other thing is that although internet isn't great in some of the communities, there is a certain amount of internet service. So people are, local people, they kind of know what's going on out there. And like, you know, they obviously read things that are probably not helpful, but they also, you know, their expectations are different from maybe what they were when there was not much communication with quote unquote the outside world. And, you know, among those expectations, obviously, is to enjoy the same level of health and safety that they see other people do.
Well, I think we're gonna have to end there, but thank you so much. Really give a round of applause for Kevin for a fantastic overview. Next, and if you have questions, Kevin will be outside just for a few minutes before he goes on. Thanks.
Thank you so much.
That's great.